Welcome to SpinalSurgeryMexico.com. I'm here with Mario Simon, my neurosurgeon that specializes in many procedures, and we're here today to try to go over some of those procedures so that our patients will have a better understanding. Dr. Simon, they always go to their doctor and they tell them they need a fusion or they need this or that or laminectomy, and a lot of times they don't really know what they've been told. They're laymen, I
understand.
Not a doctor, and they don't really know the difference between the two. I know that that you studied in Austria with a gentleman that taught you stabilization versus fusion at all cost if possible.
Yep.
And today I'd like for you to kind of explain the difference between the stabilization, if you can do it, and if you can't, why, and what you would do in other procedures instead of the stabilization, and why you couldn't do the stabilization, and why x-rays are so important to tell the people exactly what makes the x-rays be so important, because most people seem to think that if you have an MRI, it tells
you
the
don't
whole
need
story.
x-rays.
You don't need x-rays.
I have heard a lot of that. Well, as you just said, the x-rays are very, very important. I mean, I don't see a patient from spine problem, even if it's cervical, thoracic, or lumbar, without x-rays. They give us a lot of information. In order to explain what happens when you need a spinal surgery and what is that kind of stabilization besides fusion, I'm going to try to show you in these different models what is that thing about stabilization. This is a model of the lumbar spine, which has been already operated on. But I don't want you to focus on the model it has of spinal implants, but in the shape of the vertebra. The lumbar vertebrae are big. This is the anterior part of the vertebra. Our intestines are here. And this is the back part. This is the spinous processes, which you can feel touching your back, or you see spine. There is the buttock, okay? And these vertebrae form a canal where the spinal cord goes. So the importance of that canal is to have such dimensions that can harbor there the spinal cord and the roots, which goes out from that canal by these little holes, okay? If the architecture of that canal it's lost because of degenerative changes, for example, or for trauma, then the spinal cord or the spinal roots can get compressed. And that's what gives the patient a problem. For example, sciatic pain or different kind of pain in the legs, buttocks, and the back pain also. This degenerative process causes the articular processes of the vertebra to grow also and to narrow the space where the spinal root goes out from that canal. So there are different kinds of pathology that you can encounter. For example, acute trauma, where there are fractures of the vertebra or the disc, or mainly degenerative problems.
Degenerative
problems, which causes sometimes the loss of stability of that column.
And that's how you tell with the x-rays?
Yeah, exactly. Because the MRI is a static study. You are laid down during the study and you don't allow to move during the study.
Right.
So your spine stands still at that moment. So when I order x-rays, I always order flexion and extension lateral views in order to see if there is any abnormal movement of each segment.
Okay.
That gives me the idea if there is already instability in that segment, and that way I can have the whole picture of the patient, and decide which surgery would be better for that patient. Sometimes only stabilization, it's enough to take away the back pain, for example. Sometimes the discs are broken and you have degenerative problem in the spine with growing of the articular facets, and you need to remove those articular facets, but that makes that segment unstable. So you have...
So you could have, facet joint disease.
Yeah, facet joint disease, that's it. Also, there is a big ligament inside the canal, which is called ligamentum flavum, which sometimes it gets bigger than usual because of abnormal movements, and the time goes by, it becomes bigger, and that narrows the canal also. So sometimes you have to take part of the bone, part of the ligaments, and part of the facets in order to open that canal and get rid of the compression of the nerve roots or the spinal cord, depending on the level.
Now, is that a laminectomy?
That's a laminectomy. You can see in this model, this is the spinous process. There you have the lamina here and here. And in this segment, you don't have lamina or spinous process, because in this model, you can see a complete laminectomy, which opens that canal.
And that takes the pressure off of the spinal cord.
Exactly. You open that canal, you take off the pressure from the spinal roots and the cord, but as you remove that kind or that amount of bone and the articular processes, that spine becomes unstable. So you need to put some implants in order to stabilize that. Sometimes the implants, like in this model, was a case of a patient with a vertebral tumor. You have to remove the whole vertebra and put an implant instead of the vertebra, also with bone grafts, and also transpedicular screws, as this model, in order to make a 360 degrees stabilization and fusion in this case. This is a model for fusion.
So the transpedicular screws, so that our patients will try to understand better, the transpedicular screws have a flex head, or?
Not in this model, but there are models who have a hinge in the screw. I'm going to show you first this model, which is a rigid one for fusion. You can see the movement of flexion and extension in this segment.
That's the normal.
That's a normal movement of the spine, flexion and extension. It's what everybody does all day long, flexion and extension, okay? You can see that there is a movement between the fifth lumbar vertebra and the sacrum. You also have this slight movement. The movement between two vertebrae is just slightly, like 1 to 3 millimeters. But if you take into account the whole spine, you can bend over or have a wide range of movement in flexion and extension. In this case, you can see the little movement between L5 and S1, and the movement here between L2 and L3. But the segment which is fused, there is no movement at all, nothing, because this is a rigid implant.
So that you don't have your normal, this is where we get into the discussion of
stabilization and fusion
versus the fusion.
Exactly.
And stabilization is always much better if possible, because it allows you your normal movement of the segments that you had prior to the surgery.
Exactly. And if you make a fusion, for example, in this model, you have this fused segment which is rigid, but that allows the non-fused segments to be more unstable or have more movement. We call that adjacent segment failure, and it's because of the fusion. In this other model...
Now, let me just ask you one question here so that we understand. Stabilization can be done with only 2 segments. Is that correct?
Yeah, that's what is recommended.
Okay. It becomes unstable. It's not stable for more than 2 segments.
That's it.
So that's when you have to do a fusion.
Yeah, if you need to operate on more than 3 levels, you had to do a fusion because of the force that would be charged in those screws or in that system in more than 3 levels would be fatal, because the system could break or won't do its function of stabilization.
The normal function that it's designed for.
That it's designed for. For example, you can have, in this model, you can see that although it has screws and roots here, these screws have a hinge between the head and the screw itself.
And these are transpedicular screws.
Also transpedicular screws.
So they move like this.
Exactly. You can see, if I move this model, you can see a lot of movement in the segment above the stabilization, but you can see that although it has transpedicular screws, you still have that flexion movement
that you normally
had without screws. So in this system, we can stabilize and prevent from translational movement, abnormal movement, but we left the normal flexion and extension movement. You can see here that you have movement between the spinous processes, although you have the screws. And you can see how the disc space becomes narrower, although you have the screws.
So you have your everyday normal functions.
Yep.
And that's why you, if you can, you always prefer this to a fusion.
Yeah, I always try to get this before any fusion, if the patient allows. I mean, if the patient's problem allows to do this. Not always is the case. Sometimes the degenerative column or spine have a problem in various levels, in several levels, so you cannot do this kind of surgery. You have to fuse sometimes.
Now you hear a lot of people say that I want minimal invasive surgery. And of course, as a surgeon, you would love to be able to do that all the time if you could, but you have the nerve roots that come out. And a lot of times with doing a microscope surgery, you can't get to the nerve root to open it up so that the nerve root can come out. Am I correct in that, or?
Well, that thing about minimally invasive surgery can be done with this. I mean, we can put transpedicular screws in that kind of, modality of surgery without big openings. But if you want really to decompress the nerves on the spinal canal, sometimes minimally invasive just doesn't work, because you don't have enough space there in order to decompress precisely all the structures or neural structures, which is the main goal of the surgery a lot of times.
To relieve the pressure.
So there are some patients that doesn't have too much problem with spinal roots. For example, they have a lot of back pain just because of instability. And you can do a minimally invasive transpedicular screws, this kind with hinge, and stabilize the segment, and that's it. And you get the patient rid of the back pain. But if the patient has several problems like hypertrophic ligamentum flavum or hypertrophic facets, then you have to make space. And you're not able to make space if you have a 5 millimeter incision. You need to make space.
So you have
space goes
you have to
with
be
space.
able to get in to see it to do.
Yeah.
Now you can determine that before a surgery.
You have to. I don't go to surgery, I mean, to know what I'm going to do there. I always have a plan, and I try to stick to the plan 100%. Sometimes you have to make changes at the time of surgery, but the minor you do of changes, the better. If you have a whole plan of what you're going to do, what the patient needs, your results going to be better always. If you have this plan, but you the time of surgery you do another thing completely different from what you plan or what you're trying to achieve for the patient, you're lost.
What you're trying to accomplish.
Yeah. So
Okay.
that's why I do x-rays, I do CAT scan when it's necessary, or MRI, always MRI and x-rays, in order to have the whole picture of what's happening and what the patient needs.
Just like a law student would prepare for a case,
Yeah,
you also prepare for your case.
always.
And that's when you're able to know exactly how you're going to treat this patient and
Yeah.
in what manner you're going to go.
And to offer better results.
Exactly. Now, I noticed that you have some of the C levels, the cervicals, and I have a video on my webpage that shows the artificial disc, which is the much more preferred because it allows you all of your natural movement of the neck of what you normally have. Now with that, you can only do 2 levels to be able to, with the artificial disc, is that correct?
Yes. I have these 2 models of C-spine. This is the anterior part of the C-spine and the posterior. You can see here the spinous processes, which also you can feel in the back of your neck. And you can see here the movement that normally have the C-spine. According to the problem that the patient has, for example, a fracture, you sometimes need to use plates in order to fuse that segment and stabilize. That's always done in trauma victims. But in degenerative cases, when the discs are sick and are compressing the nerves, you have to take out the disc. And if there is no trauma fractures, you can put, instead of having a fusion with a plate, which is a very, very old procedure, you can put instead an artificial disc and keep moving the C-spine. You don't have to lose that movement.
And that's with the Retayo.
That's what Retayo does. It's really a very nice surgery, very clean. You go from the front of the neck with a little incision, according to if you're going to work 1 or 2 levels, but it's not more than 1.5 inch incision. And you don't have to cut a lot of tissues there. When you do the surgery and make the bed for the implant, you have to be very obsessive to do it perfect. That's why I always use microscope to do that.
Okay.
Always.
Well, I certainly hope that this has been more informative to the people that are interested in possibly having a surgery with us. And I can't thank you for taking the time out of your day to help explain to some of the people some of the different procedures and why, if you can, stabilization is better for them than fusion, and why you would do a fusion when you have to, and why, and the different techniques. And I would like to thank you for taking your time to help explain that to us today.
My pleasure, Greg.
Thank you, Dr. Simone. And thank you for watching the video. And we'll be sure to try to have more videos for you as time goes along. Thank you.